can. So, welcome everyone to. This will be the final Scrutiny Committee meeting in its current form. So it's the first in that, and also it's the first time we're trying to use a sort of a hybrid system. So I'm just wondering, do we need to say about the...
So colleagues from the NHS will be joining us via Zoom for the item on access to dental services. Unfortunately, one of the screens in the chamber isn't working, so it will just be the screen on this side, so people might have to turn around, but they will be able to watch the webcast, so they'll be able to see you, and obviously you'll be able to see them, so hopefully it'll all go smoothly, but it is our first time, so just bear with us if we struggle.
In terms of the other housekeeping arrangement, I don't think we need to go through that because I think everybody knows where the fire exits are and the toilets, etc. Okay. So, apologies. Have we had any apologies? Thank you. Thank you, Jenny. Any items? Sorry. Any items where we need to exclude the press or the public? And I don't think we have, do we? No. No items. Any declarations of interest?
I'm a patient in some of the GP practices that we're talking about later on. I can't remember which item it is, but I'm a patient there.
Thank you, Aptison. Lucy.
I'm also a patient of one of the practices that we'll be discussing later under the primary care item.
Okay. So can we go through the minutes of the last meeting starting on page 9 of the pack for accuracy. I'll take accuracy and matters arising, I think, at the same time. Is there anything on page 1? Sorry, I beg your pardon. On page 9. Anything on page 10? Page 11? 12? 13? 14, 15, 16, go on page 17, and page 18. So, can we accept them as a true record? Any matters arising? No one indicating so. We'll move on then to item 6, public questions and petitions. So I'll hand over to Emily.
Okay, so we have had some public questions submitted from Mick Souter, who is the chair of Sheffield Save Our NHS. He's not able to be here, so he's asked me to read them out on his behalf, and we have pulled together answers from a legal and governance perspective, so I'll give those at the same time, and if members of the committee want to add to that at any point, we can do. Okay, so question 1. Assuming that the Health and Care Bill is passed in Parliament and that the South Yorkshire Integrated Care System takes on statutory commissioning powers as a result, do members of this Scrutiny Committee feel confident that the new committee system governance arrangements for Sheffield will properly cater for unhampered scrutiny of both health and care provision? Okay, so the response we've pulled together is that post-May, it is proposed that statutory health scrutiny will be undertaken by a standing health scrutiny subcommittee of the Adult Health and Social Care Policy Committee, including members from the Education, Children and Families Policy Committee. There is no requirement for a separate scrutiny function relating to the Council's direct responsibilities, as in a committee system, cross-party check and challenge and cross-party policy development is built into every decision-making committee and full council. Councillors are committed to carrying out their statutory scrutiny duties effectively and recognise that it will be a steep learning curve and there will be ongoing refinement of the new system in the early months and years. A review of the new system will therefore be carried out at 6 months. We are also talking to colleagues across South Yorkshire about the future of the South Yorkshire, Derbyshire and Nottinghamshire Joint Health Overview and Scrutiny Committee to ensure our health scrutiny responsibilities are carried out effectively across the ICS as well as in Sheffield. Question 2. Is there not a potential for conflict of interest if the new Health and Care Policy Committee is responsible for most decision-making regarding social care policy and also for the transferred statutory powers of scrutiny over health and care decisions locally? And the response to that is that the statutory health scrutiny function, NHS Act 2006 section 244, covers matters relating to the health service or on which NHS bodies or relevant health service providers must consult the local authority. As health service providers are NHS bodies, not local authority bodies, no conflict should arise. And question 3, how will the new Health and Care Policy Committee, which we understand is what this scrutiny committee will become after May, work effectively with the Joint Commissioning Committee and Health and Care Partnership Board? Will it have genuine decision-making powers regarding social care provision and working conditions for care workers in Sheffield? And in response, it's more accurate to say that after May, the Adult Health and Social Care Policy Committee will take on the responsibilities of the current cooperative executive and relevant cooperative executive members. And as per question 1, scrutiny is built in a committee system of governance. An effective relationship with the Joint Commissioning Committee will be embedded through chairs of the relevant policy committees being members of the Joint Commissioning Committee, and current liaison with Health and Care Partnership bodies across the system will continue and is likely to be led by the chair of the relevant policy committee or a committee nominee, but only the policy committee will have decision-making powers in the same way that the executive does in the current system.
Thank you, Emily. So I'm going to put this. Are we happy with the response to those questions that you know, as it stands at the moment? Obviously, there are a lot of uncertainties in terms of the health and care legislation. Ruth.
Thank you. Yeah, the final answer kind of raises another question, which is if the chair becomes the person responsible for liaising with the external bodies like the JCC, how do we avoid that becoming like a cabinet member function again? See what I mean? If that falls to one person.
That is a question, well, a good question. I don't necessarily know the answer to it here and now. From a... Bear with me, Ruth.
I'm not entirely sure. I have had some liaison with colleagues in legal. I'm just going to check and see if I can see if there's anything in there that can respond. Otherwise, I'll have to come back to you if that's okay. I think I'm not sure how about the relationship between the decision-making powers of the JCC and the decision-making powers of the policy committee. So I'll need to go away and come back. Is that okay?
Thanks very much, Emily. Yeah.
I mean, in amongst all this, there's still a lot of uncertainties in terms of the legislation that's currently going through Parliament, I guess. So it's not easy to give a clear answer at this stage. Lucy.
Can I just ask what we know about the new arrangements in terms of the public being able to access them?
I'm going to have to pass these over to Emily because I've not been involved in the discussions that have been going on in the governance committee. There is the arrangements are going to full council next week, and there will be a debate then. But in the meantime, can you just answer that?
My understanding is that all formal decision-making meetings will be open to the public in the way that they are now, and that we are going to put in place mechanisms to help people get their question to the right committee, recognising that now we've got LACs, we've got, there'll be policy committees, there's full council, so I think there's an intention to provide advice to people in a kind of triage sense, to make sure that their question gets to the right committee, but there isn't an intention to dictate to people where that would be. So I will, again, it's all going to full council next week for decisions, but I will dig out the governance committee proposals and send them to you. There's a section on public questions and access to meetings, and that will have the detail. So I'll look for that and send it through.
I think the other thing to add to that is that there is to be a review of the arrangements. Is it 6 months? After 6 months, and inevitably there will be, you know, we'll find thing. You know, the thing is we've got to go ahead with something, and there'll be an opportunity to review anything that is not working as we would like it after 6 months. That's my understanding. Yeah. And I've got Alan.
Yeah, thanks, Chair. It was regarding the review that I was going to speak, so you've covered that. Thank you.
Okay. So, are we happy if in sending that response to those public questions? Are we comfortable with that? Okay.
Could you add the reviews in there? Yeah, no, I think that satisfies the questions. Thank you.
Okay. Thank you, colleagues, for that. So, right, this is the test of the technology. So, item 7, access to dental services, and we have. If you could introduce yourselves, I presume that everyone is able to, you know, or everybody's logged in remotely in order to do that. Yeah. So hand over to Margaret. Would you like to begin? We're not hearing you.
You're on mute, Margaret.
Right.
You're back on mute. Sorry.
Can you hear me now? Hello?
Yes, we can hear you.
Hi, I'm Margaret Naylor. I'm chair of South Yorkshire LDN.
I'm Debbie Stovin. I'm the dental commissioning manager at for NHS England in South Yorkshire and Bastille.
Sarah, could you introduce yourself, please?
Right, I'm Sarah Robertson. I'm consultant in dental public health, working with NHSC and I, supporting NHS England around commissioning of dental services.
Okay. Well, I'll introduce myself. I'm Steve Harris. I'm the chair of the Health Communities Adult Social Care Scrutiny Committee. Welcome today. So I think if we can hand over to you, if we'd like to present your report, and then I'll open it up to members for any questions that they want to put, if that's okay. Are you happy with that procedure?
Okay, I'll start. So this is obviously a recall back to the Scrutiny Committee. We came in January of last year, where I think we had a much more detailed discussion with Emma Wilson, who's the overall sort of manager of co-commissioning for us and public health. So we've produced sort of more of an update report for you this time. Obviously, a lot of discussion last time was regarding difficulties accessing dentistry, and we talked about the restrictions on the dental world, really. I think you'll be able to see from the stakeholder bulletins that we issue throughout the year and the latest one issued in January, which we attached with this paper, we're in a slightly different position, also still got many challenges in dentistry. So we've focused on some of the, I think, sort of more positive aspects of dentistry for you at the minute. So last year we were reporting that dentists were under quite a few restrictions, which were following guidance from the National Office and the Chief Dental Officer. So general dentistry in high streets was delivering a minimum of 45% of their normal yearly activity. Over this last year, that's actually been increasing in a phased way. So we're now in Q4 of this year. They're meant to be delivering a minimum of 85% of their normal activity from Q4. So that's a substantial difference from last year. That's not been without challenge. And obviously they are still in the throes of doing that at the minute. But they have obviously throughout the year still had many challenges regarding effects through the COVID pandemic, effects on workforce, etc., and the restrictions that they have had to abide by, which has meant they've had to keep a lot of conditions running in the practices to protect both the staff and the public that are going in there. We do still have issues with access to dentistry. They are not back in a normal world yet. We are still experiencing with our dentists waiting lists for people who want more routine care. The focus is still very much being on urgent care and dealing with vulnerable patients as a priority group. We have, through this last quarter in particular, been able to put some additional non-recurrent resources into urgent care, which has been supported by primary care as well, to some extent, to try and get more people who are in need of urgent care treated. And you will know from news that there's been a national incentive this last quarter to actually do some additional out-of-hours sessions, which has been taken on in Yorkshire and Humber and in Sheffield as well. So the report gives a little bit of information on that, and that is still ongoing at the minute, but that will cease at the end of March. We have also been running a review of a scheme which we refer to as an access scheme, which is really trying to increase access for people in certain constituencies. And in Sheffield, we had 2 constituencies in Brightside and Hillsborough and Heeley involved in this scheme. And that's been evaluated through the year and has actually been really successful to try and allow better access in certain areas for patients to receive care. We've undertaken a review of that scheme this year, and we did change the way it worked partway through the year to make it more looking at outcome focus and trying to get more people dentally fit. We've just agreed and managed to secure some additional, to sort of keep the funding on that, to extend that for another year. So practices involved in that scheme have been informed of that. So we're just working with them at the minute in terms of making sure they are still able to continue to provide that additional level of service and what that means. And also, we've also reviewed what we term as our flexible commissioning approach, which is very much focused on helping access to treatment, but also working on some more preventative measures. Which then frees up the dentist to see more people by using a wider workforce team. And that again has also been extended for a further year. And again, we're just in talks with practices at the minute to extend that, but also looking at the wider opportunities of making that available for other practices in line with our needs assessment, which we've referred to in the paper. So we're hoping that we'll have be able to extend that out to some other practices. There's obviously certain conditions that need to be met with that, and there's requirements that they need to do to be part of those schemes. But that's a really positive step, I think, for us in Yorkshire and Humber, that we're able to do that. And it has been one of the first schemes nationally regarding sort of looking at alternative ways of commissioning dentistry, and there are other schemes now kicking off throughout the country, but ours has been looking like it has been a level of success, so we are keen to try and embrace that and try and link those two schemes together, but trying to make sure we actually do have them in the areas where we need them, linked into the needs assessment scheme. I'm going to just stop there, and I'm just wondering if there's anything Margaret or Sarah would like to add at this point before questions start.
The only thing I would mention is that we have endeavoured to look after care homes throughout this period, in one way or another, by utilising the sort of specific ROC scheme, which is considered the gold standard for care in care homes. But that's the only thing I would want to add.
And Sarah, is there anything you'd like to add? Before, I just mentioned before invite questions, I'm going to ask Lucy to present we have in our reports pack a report from HealthWatch, but just, Sarah, anything to add before I do that?
I think just to add about the flexible commissioning scheme, we've now got a referral route in Sheffield from health visiting teams into the practices that have signed up for the flexible commissioning programme. So hopefully children that are deemed to be at higher risk of poor oral health, identified by health visitors, should be able to have easier access now to the dental care they need. And that offer is also there for social care as well.
Thank you, Sarah. Lucy, would you like to speak on the HealthWatch report in the papers? Lucy Davis.
Thank you. So the briefing that we put together kind of follows on from a briefing, again, that we did last year for Scrutiny. And I think the themes are probably similar. So it's really just highlighting that although we know that there have been sort of steps towards returning services, there are still a lot of difficulties that the public are encountering, which I'm sure as councillors you've probably come across as well. So just to highlight that HealthWatch Sheffield, currently 1 in 4 calls that we get is about dentistry, and I will say that prior to COVID, I don't know what the figure was, but actually it was quite rare that we got phone calls in relation to dentistry. Well, not rare, but compared to other areas, it was not a prominent area of concern for us in Sheffield, compared to many other health watches that heard an awful lot about it. So the sort of ongoing themes really are broadly around, I think the biggest impact is for people that prior to COVID weren't linked to a dental surgery, so people that didn't have a regular dentist that they saw are now finding it, I'd say, close to impossible to get themselves linked to a dentist for routine care. For urgent care, there should, there are options in place. I will say that for some people who are experiencing difficulties but who don't meet the threshold of urgent, that's still a sort of large group of people who are perhaps experiencing some level of pain, discomfort through dental problems that don't meet that urgent threshold, who aren't able to access what's regarded as more routine care. And I guess one of our growing concerns really is around children in particular. So we had an increase in number of calls from parents whose children were born maybe sort of during the pandemic or not long before the pandemic, who'd never had that opportunity to connect their child to a dental surgery. And now they're in a position where they're not able to find an NHS dentist that can add them to their list. I know they don't technically have a list, but that can offer them an appointment. Just to say, there is, if you look on NHS, the NHS website, the information about dentists that are taking on new NHS patients in Sheffield, I think it's something like around 20%, or when we looked it was around 20% of those Dentists said that they were taking on new NHS patients. We did a sort of mystery shopper exercise a couple of months ago and got in contact with all of those dentists. And what we found was that actually even those that said they were either not taking people on or could at best add them to a waiting list, and the waiting list lengths were in the region of sort of 2 years or more potentially before they'd get seen. So it's that group of people really that, you know, are most impacted, people who don't already have some connection to a surgery. But we do welcome the sort of positive developments that are happening around flexible commissioning and the dental access project. So it's really good to hear about those steps. I guess it's that next bit of the journey in trying to reach people more routinely who are being excluded from the services at the moment. Thank you.
Thank you, Lucy. Okay, so I'll open it up to members' questions, and could I ask you, and we've got a lot to get through today, to keep your questions brief, succinct, and to the point, so that we get through the other items on the agenda, because this room is booked for the corporate executive at 1:30, and we need to clear the room. So there's that incentive to keep your questions succinct, if I may. So any questions? Or even comments at this stage? I'll take questions and comments at the same time. So, Councillor Alan Hooper.
Thank you, Chair. Yeah, I know it's the adult scrutiny, but I want to talk about children. We've had this report from Greg Fell about tooth decay in children, and it stretches back from 2007 to 2008 to the pandemic in 18-19. And Sheffield comes out for the under fives worst in the area, and almost twice in 2018-19, twice the national average of tooth decay. I'm worried about these figures. We've got these figures, but what about the children that we don't know about? So I think the issue is far greater than this. I'm just wondering, if I could ask a question, what's being done about it with under 5-year-olds? Because if we catch them young and get them used to the dentist, used to looking after the teeth, we'll have less trouble in later life. I would also ask the question as well about travel. Difficult enough to get a dentist for most people, but travel to a dentist. And it's going to become more important with the climate change and fuel prices for people to actually travel to a dentist. I travel 6 miles across the city for a dentist. I'm fortunate that I've got one in regular. And as well, I'd take my grandson with me, and he's experiencing at 3-4-year-old the dentist, so he gets used to it. But I think if we can tackle the problem early, it would be good. So I would ask the question, if we have in the later figures in 2018, 2019, if the situation has improved. And I believe that through COVID, it's probably worse now than what it was in 18-19. Thank you, Chair.
Thank you. So, is it anyone, can anyone, or would anyone like to respond to that? I can't see.
You don't need to come in.
Sarah, sorry. Sorry, with where I am, I can't see people's names. Okay, Sarah.
You're absolutely right in terms of Sheffield's extremely high levels of tooth decay. So in 2018-19, there were 41% of 5-year-olds who were surveyed from schools in Sheffield that had experience of one or more decayed, missing or filled teeth, which was significantly higher than the national average of only around 23%, and the highest level in Yorkshire number. We haven't got any more data since then, so obviously that was pre-pandemic. There is currently another 5-year-old survey underway, so we hope to have a new set of data probably by the end of the year, so that will give a little bit more of an indication of have things got worse or have they stayed the same. In terms of what's being done for the under 5s, I think, you know, it is important to remember that, you know, on the one side we have dental services, and Debbie's explained about the you know, the mechanisms to try and improve access there, and the flexible commissioning programme which Sheffield's involved with. But the other side of it is the oral health improvement programmes, which are a council, local authority responsibility, and there is an awful lot of work being done in that kind of age group. So there's universal provision of oral health packs at all 9 to 12 month health visitor assessments, and also to 2-year-olds in deprived areas, again via health visitors and family centres. There's also a supervised toothbrushing scheme, which runs in schools and nurseries and special schools in Sheffield. And there's various other kind of oral health training that's undertaken by the oral health promotion team for early years practitioners, schools, education. So there's a number of different things that are being used from the local authority side of things as well, oral health improvement programs to try and tackle the prevention side of things, basically, so that we don't get to the stage of children needing extensive treatment. And the other thing to add as well is, and this has been mentioned at previous scrutinies, that there is still work underway looking at the feasibility of water fluoridation for the entire South Yorkshire area, which would obviously have a huge impact on levels of tooth decay, particularly amongst children. So from the 2018 health monitoring report, if all 5-year-olds in deprived areas received water fluoridation, there would be estimated a fall of 28% of children experiencing tooth decay and 45 to 68% less tooth extractions, which would be great for Sheffield, given that we're one of the top 3 areas in terms of the number of tooth extractions that happen in England. So that could have a huge impact in Sheffield.
Thank you for that. I have, sorry, which order? Abtisam first, I think. So, Abtisam.
Thank you, Chair. I have to agree with Councillor Hooper's comments about the inadequacy of dental care for under 5-year-olds. I'm just thinking about the correlation between, because under 5s generally would expect them to receive from Greg's report support within nurseries on early dental hygiene. And I know Ofsted is pushing the importance of oral hygiene as well in their inspections with early years providers. The difficulty that we have is that within areas of deprivation, the take-up of early years provision, so any 2-year-old or 3-year-old is very, very low. And I'm just thinking about the pattern that we have there that I've seen in the report. Health visitors will be doing checks, but that's a check once a year for 2-year-olds, and there's very little follow-up after that point. So I think that the question that I have is what work is being done together with sort of the council's early years team to encourage take-up within areas of deprivation, so that actually parents and children are getting the support within nurseries, particularly in those areas, because from the work that I've done with early years providers, that is the key issue, that actually take-up is very, very low in those areas, and that's probably adding to the issue of children under 5 having poorer oral health. So I'm just thinking what pieces of work are actually being doing together collaboratively with the early years team within the local authority.
Would anyone like to sort of respond to that comment? Yeah. So,
I'm
Margaret.
not sure I can answer it totally. One of the health visitors should recommend that a child goes to a dentist as soon as they get to 1 year old. Unfortunately, with COVID, for the last 2 years, that hasn't been possible because, of course, a baby isn't urgent and isn't a priority. At the moment, the latest information we've got through is that children should be prioritised for dental treatment. However, with the early years, with children below 5, we rely on parents to bring the child. We rely on the education of the parents. I don't know whether Sarah has anything to add to that.
Well, I think there's a lot of awareness raising. Certainly,
Yeah.
The majority of nurseries in Sheffield, in the deprived areas, have got supervised toothbrushing schemes set up, and that, you know, obviously raises awareness amongst families of the importance of oral health. And you know, the early years staff receive regular training from the oral health promotion team as well. So there is work being done with those settings. And all opportunities that we get, it's kind of promoting the how do you find a dentist kind of message as well. But yeah, as Margaret said, there have been challenges, you know, getting these children seen over the last couple of years. And I think that's probably something where perhaps more work could be done in terms of you know, encouraging people back to the dentist, making that first step to make that first appointment. But it does rely on their capacity being there.
Okay, thank you for that. I have Councillor Ruth Mersereau and then Councillor Ruth Milsom.
Yeah, I'm just remembering back to my childhood, and there used to be a mobile dentist that would come to the school, and I'm wondering if there are any opportunities for this in Sheffield to have a mobile dentistry service, including oral hygiene, that could come on site to schools and be available for children and people at nursery.
So in times gone by, there was school screening where you know, all children got regularly checked at school, and if they were found that they had problems with their teeth, they were then you know, a slip was sent home for the parent to then take them to the dentist and get seen. But fortunately, the evidence was that those children that were probably most in need never actually got taken to the dentist in the end to have the treatment done. So the screening element wasn't really that effective. And there are issues with, you know, not being able to do the whole range of treatment that perhaps you'd want to do if you were to take the kit to a school. Very difficult. So that has sort of fallen by the wayside, that kind of approach. It is better for a child to be taken to a dental practice to where you can have, you know, optimal infection prevention control procedures, especially in the light of COVID. And it's in a controlled environment, and you've got all the kit that you need to do the best job that you can for these children. So yeah, it isn't really the best option, taking the kit to the schools or the nurseries.
Thanks for the explanation.
Okay, Ruth. Ruth Milsom.
Thank you, Chair. I wanted to ask a little bit about what happens in schools. Greg's report, or Greg's pointers to us suggest that there are supervised toothbrushing clubs in schools, which sounds a bit optional if it's a club, but so I just wanted to ask: is that something that's actually compulsory? Is there some compulsory intervention? At least on an annual basis in schools. So sort of frequency and coverage, and does it apply to every year in primaries, say? Or, you know, if you miss out on it in year 3, do you never get it again? Or what's the coverage that we've got with interventions in schools? And given that obviously schools have had closed periods during the last couple of years, what happens about catching children up right now that they're, you know, obviously fully back in school on a stable footing?
Okay, shall I come in here, Debbie? So basically, we had a huge scheme running in Sheffield pre-pandemic. Then all the schemes had to shut for I think it was about 6 to 9 months at the beginning of the pandemic. Nationally, we were told to stop them for obvious reasons. And then they were allowed to be restarted kind of autumn 2020, but really they've not got back up and running again until about autumn 2021. You'll appreciate we have had really high rates of COVID, particularly in Sheffield, and there was obviously some concern and reluctance to get these clubs back up and running again, with concerns around the risks of transmission of COVID. So they are back, well, a lot of them are back up and running again, running under new protocols with new national COVID-19 guidance that came out for supervised toothbrushing schemes. And I believe there's around 2,000 children who are now a part of these clubs again. We're at a sort of interim stage where not all of the schools and nurseries that previously were part of the scheme feel comfortable to get them back up and running yet. And obviously you can appreciate the staff shortages as well, that's impacted on things. But many have restarted now. They tend to be the kind of preschool age, so 3 to 4 year olds, and the reception classes, because that's where it kind of tends to work easiest and fit in with the timetables, and we want to catch the children early. So the aim is to teach them the life skills of how to brush their teeth, because many children aren't getting their teeth brushed at home. Some don't even own a toothbrush. It isn't a replacement for brushing at home, it's an additional session that they do at school in a controlled way. It's gradually getting back up and running again. As I say, the target areas are the more deprived areas of Sheffield. So was there another question as well? Was that I covered it?
But it was just whether every child is exposed to some sort of intervention in each year of their primary education. Because I mean, even just a one-off in primary,
Not. It's up to the establishment whether they wish to start a supervised toothbrushing club. It needs buy-in from the staff, and they need training. So no, not every school in Sheffield or every nursery in Sheffield will be doing it. It's targeted to the more deprived areas.
Is that a likelihood in the future to step up our more early intervention, that we could have a more comprehensive and compulsory coverage with school children?
I think it's probably related to funding arrangements as well. There's a limited amount of money, and so targeting at the more deprived areas which will experience high levels of tooth decay is the way that the local authority has decided to go at the minute. It probably, if you wanted to ask further questions around this, Debbie Hanson is the lead for oral health in the council, and she works closely with Zoe Marshman, who's another consultant in dental public health, who works at Sheffield University. They would be able to give you a lot more detail on this. But I know that they are willing to expand things further, but there's probably financial barriers to how far they can go.
Lucy.
Thank you. I have got a question, but first I just wanted to make a comment still on the subject of children. I just kind of had to respond really to the comment about children getting to the dentist being reliant on parents' awareness and sort of confidence to take the first step and so on. Of course, that is a factor, but I think we need to be clear that there's a whole group of children at the moment, almost a whole generation, who for the stark reality is that their parents may be desperate to take them to the dentist, but that isn't an option because there is nowhere that will accept them. So we have parents call us who are besides themselves wanting to sort something out for their children, and they may have phoned every dentist in Sheffield and not been able to access NHS care. So that leaves only parents who can afford private care to be able to take their children to the dentist if the children aren't already registered or linked to a regular dentist. And that divide, actually, just to sort of say, I should emphasise that divide is something that applies to adults as well. So obviously there's a huge difference between those in our city who can afford private dental care and those who can't. And that divide, you know, is something which has grown hugely during COVID. So my question is just relating, actually, I'm just curious, the information that Greg Felsom shows the figures, as have already been mentioned, for decay across South Yorkshire, and that Sheffield is the worst area there. I was just wondering what Doncaster have done to improve their situation so significantly in those figures. It's a kind of notable improvement that they've made, and just in terms of their strategy and their approach, do you have any insight into what's been done there, just so that we can think about what could make a difference in Sheffield?
Is anyone able to respond to that?
Well, I wasn't aware that Doncaster's figures were so much better than Sheffield's, to be honest. I will look into that. The problem has been over the last 2 years, dentists were seeing significantly less patients. Now, hopefully, come April, when we should be seeing 100% of patients again, that the situation will improve. There are always dentists that will take on children, especially if the children are in pain. It's always difficult when people say they've rung every dentist in Sheffield, and if I've been contacted, I can get them into it. You know, I can just ring up and say, "Can you see this patient?" You know, and they've not contacted that dentist. So I'm always just a bit wary. I'm sure some people do contact every dentist and can't get in, but I'm always a bit wary about what patients say. The answer is I don't know how Doncaster have improved the figures, and I wasn't aware of it. I don't know whether you were, Sarah.
I think just to come in there, although on paper, you know, if you were to compare the 2018-19 5-year-old children rates of experience of tooth decay is 37.2% for Doncaster and 41% Sheffield. But if you actually look at the data, the confidence intervals overlap, which means that there isn't a significantly difference between Doncaster and Sheffield. They're both pretty poor, I have to say. So yeah, I think it's just being careful when you look at the data. It does appear on paper that Doncaster has got slightly lower levels of tooth decay amongst 5-year-olds, but to do with how the data is sampled and the number of children who took part in the surveys, we can't say that is statistically significant. And I don't think that Doncaster has had any different strategies really, as far as I'm aware, to those which have been used in Sheffield. One of the assets that Sheffield has is an oral health promotion team, which Doncaster doesn't have. And so, you know, there's a lot more scope for oral health improvement activities, council-led ones, in Sheffield than there are in Doncaster. So you're in a better position there, I think.
Thank you. Can I just come back briefly? Yeah, just to clarify, sorry, I should have said that obviously Doncaster, in the figures that Greg shared, had started in a much worse position. It was just the direction of travel, I guess, that I was looking at in terms of them making a significant improvement. But I hear what you're saying about the complexity of that data. And just to clarify as well that in terms of the patients that have contacted us frustrated about children, if the child is in pain or it's an urgent issue, yes, absolutely, there are different routes through Margaret that we would support them with. And so I'm really talking about people who are just looking to get their children in for that sort of first routine. Preventative appointment, just to sort of clarify that. And, you know, obviously it is always hard to know whether a person has literally called every dentist in Sheffield, but just to say we did obviously our own mystery shopping exercise, which really substantiated what we were hearing from people.
Yeah, I agree with what you say. And as I said before, the latest communication what was that dentists should start to prioritise children for routine dental care. It's a massive problem, especially as there is also a shortage of dentists at the moment. It's not that you can sort of suddenly, helicopter in another 100 dentists. You just can't. So it's a two-pronged problem.
Okay.
Thank you.
Right. Final call for any questions or comments, or if I guess would like to anything to add in before I close this item.
If I can just add one point, please. Just I know Margaret referred to we're expecting dentists to be able to go for their activity to be 100% from April. That's not yet confirmed. We are expecting case, but we are still waiting for notification from the national team in terms of what that will be post the end of March. Hopefully, we will be back to a new normal, if you like, but that's still not yet confirmed. But obviously, once it is, there will be communications out.
Thank you for that. Okay, so can I ask members, can we note the report and thank Debbie, Margaret and Sarah for joining us in this. It's a bit of a guinea pig for us having a hybrid system in the council chamber, and thank you for attending. So can we note the report, members? Thank you very much.
Okay. Thank you.
Thank you.
Bye-bye. Right. If I may, just in terms of logistics, can we take item 10 now? While yeah, because we're running slightly early in terms of the timetable, but yeah.
Okay, so I can't believe we're running early for starters. This is the so back in 2019-20, the Scrutiny Committee set up a working group to look at continent services. It published its report, and unfortunately it's taken us till now to get to organise a response from the NHS to the recommendations that were in the report. We held an informal meeting of the committee last week to go through that response, so everyone had an opportunity to talk to the NHS about that. The key messages from that meeting are in the report here. So it's here as a way of kind of formally getting that NHS response on the record, and the recommendations are that you note the response to the committee's report, note the key points from the discussion last week, and then request that next year the NHS returns to the appropriate committee to give an update on progress. And that's it really. Over to you if there's any questions. We weren't intending a huge discussion on this one. It was more of a formality of getting the response on the public record.
Yeah, we did have quite an opportunity to have quite a thorough discussion about this, but Gary, did you indicate? Yeah.
Yes, thanks, Chair. I'm really pleased to see this. When we pushed it through for the year, it was needed, and so I'm pleased to see it, Chair, and hope we can build on that in the new committees. Thanks.
Okay. Anyone else? In which case, can we formally agree that item? Yeah. Okay.
I'll go and retrieve.
Right. One brief moment while we see whether we can move on to the next item. Okay, so if we can move on to item 8 on the agenda, and can I welcome, well, would you like to introduce yourselves, Lucy and Jackie? I think you may already know people. Anyway, over to you to introduce yourselves.
My name is Lucy Ettridge, I'm Deputy Director.
Sorry, we've got a
Sorry,
sound.
wrong side, thank you. I'm Lucy, I'm the Deputy Director of Engagement, Communications and Equality for NHS Sheffield CCG, and it's my team that's leading the consultation for the plan that's with you today. Thank you.
Hi, and I'm Jackie Mills, I'm Director of Finance at Sheffield CCG, and I'm the lead for estates.
Okay, so can I hand over to you to present the report then, please? Thanks.
Yeah, so if I make a start and then Lucy will cover all the detail in terms of our plans. First of all, apologies for the late circulation of this paper. I know it's quite a long paper and you've had very little time to go through it. So I think our plan is just to take you through a bit of that paper just to make sure that everyone's up to speed, if that's okay. So if I just do a bit of an introduction, I think we last came to talk to you, I think it was September 2021, just to give you some initial understanding of the plans. I think at the time we came to talk to you, we had been in front of the Department of Health and NHS England Joint Investment Subcommittee. So at that point, sometime I think last June, they'd given us verbal indication that they were supportive of the programme, but it had to be subject to Treasury approval. We got Treasury formal approval yesterday, so it's been quite a long drawn-out process to actually go through that approval process, but we've got now sign-off for the programme, which means we can proceed. You will see from the paper it's a really tight timescale that we're being asked to work to, so the Treasury have set a hard deadline of projects being complete by December 2023. I think we just need to acknowledge that some of the challenges of trying to engage people, we're working to tight timescales, but we're trying to make sure that we carve out sufficient time to properly engage and understand people's views. And Lucy will go through that in a bit more detail. I think I just wanted to just take through the plans for each of the 5 main health centres, and then the paper also talks about some of the smaller schemes that we've got, so I can cover those at the end. There are 3 primary care networks involved in the Transformation Hubs part of this project. 2 of those are in our Foundry primary care network, so that's places around Page Hall, Pitsmoor, Burngreave, that part of the city. So there are 2 proposed hubs. At the moment, a number of practices are engaged with considering whether they want to move into a new health centre in these areas. They're not required to formally sign up to this, they are just part of the working up of plans. We won't be asking them to sign up until we've been through the consultation and we know the outcome of that consultation. So the first hub in Foundry is what we call Hub 1. That's at the moment involves practices Pitsmoor, Burngreave, including their Cornerstone branch, and the Sheffield Medical Centre. The sites that we have a long list of sites. You'll know from those people that know these areas of the city, there's quite a limited space in terms of open spaces for development. The 2 shortlisted sites are at Catherine Road and Sheffield Medical Centre, but as Lucy will explain, they are proposed sites, they're not fixed. The second hub in Foundry includes practices at Page Hall, Upwell Street, and the Herrish Road branch of Burngreave Surgery. So there was a very limited number of sites available, so the preferred site identified by the practices there is Rushby Street. And then if we move into the SAPA network, we've got 2 proposed health centres in SAPA. So the first hub involves Firth Park Surgery, Shire Green Surgery, Elm Lane and Dunning Road. And again, there is one proposed site there, which is at the Concord Centre, which people will be aware is also a leisure centre that the council are proposing to upgrade. And then the second site in Sapper involves the healthcare surgery, Buchanan Road, Southey Green, Melrose and Margetson branch surgery. And the proposed site there is on the edge of Buchanan Road and Wordsworth Avenue. And then finally, Cttee. So initially, and this is part of the reason that the paper was delayed, because we were still in ongoing consultation with the practices. The initial proposal that was brought forward by the practices involved the Clover City practice, the Mulberry practice, and then Devonshire Green and their branch site at Hanover. Devonshire Green confirmed on Monday that they no longer wanted to proceed with their involvement in this scheme. Initially, when Devonshire Green were involved, they were keen to make sure that the proposed site wasn't too far away from their existing site. So we had identified Star House as the preferred location. Given that Devonshire Green have now indicated they don't want to proceed in this, I think we go back to the long list of sites because Mulberry and Cttee probably have more flexibility in terms of the sites that they would like to consider. So I think the main thing to say is that these proposals were brought forward by the practices themselves. They were a number of years ago. I think initially when they put forward their initial plans, we were back in 2016. So obviously the pandemic has had an impact in how these practices deliver their services and has an impact on how we might respond to those changing needs. So it's the practices that we are working alongside, but we're now keen to understand what the practices, the population's view of the proposals are. We have done work with the practices around what it means for them to move into these new health centres. So we have provided some initial financial reviews for the practices to consider what it will mean for them in moving into that. They'll consider the patient feedback in terms of what their patients feel, and then ultimately they'll be asked to make a decision about whether they want to proceed forward in light of that feedback around September time. So I think that was the main bits I just wanted to summarise from the paper. I don't know if we want to stop there and ask any specific questions around that, or whether we want to cover the consultation and then open it at the end. I'm happy either way.
I have Abtisan's indicated. Is that a specific question? Okay, Abtisan.
Okay, I'll take you through some of the consultation plan. So the consultation plan is here today for your approval, and I'd really love to know any suggestions on how we can improve reach, of any meetings we've missed, any groups we've missed, anything that we can do to make it as comprehensive as possible. And the consultation plan is building on the engagement that we've only started this week. For the reasons that Jack has explained, actually we've only just had approval from the Treasury, which meant that we couldn't really tell anybody about the schemes because we weren't confident of the investment. So it's really squeezed the pre-consultation engagement period. So we're starting today, and we're going to do that for a couple of months, working with the voluntary community sector to make sure the voice of those with the greatest health needs and the seldom heard is brought in. And that information shapes the options that go into business case, and that is then what we will consult on. And the consultation will ask people for their views on the final options, and in the consultation we're hoping to be clear on what our preferred options are. So we'll say for SAPA 1, our preferred option is this, what do you think about it? And then we'll really try and understand the impact that that might have on the patients and the public. The three areas, they've got very diverse populations, and in the plan we do outline some equality profiles, and they're based on local information and national information, councils, demographic information, and also we've worked with a lot of voluntary community sector organisations, and they've given us our insights to some of the experiences of those populations and some challenges around communications and reach. So our plan is to launch the consultation week commencing the 6th of June and for 10 weeks, and not for the 12 weeks, which is seen as sort of the golden time frame for consultation. And the reason for that is that the plan is really, really tight. And Jackie explained that we need the practices to sign contracts October, November time, and then we need to sign contracts with the developers. So working back from that, we need to do the consultation, and then we will need about a month to do the analysis and the reporting. And then that report will need to go to our internal committees, because we have to really consider all the findings in a meeting before we make the decision. And we also want to share the report with this committee, or the committee that supersedes Healthier committee, so you can then make an informed choice based on what the public are telling us. So rather than giving your views blind, you're giving your views based on what the public are saying. So all that takes a couple of months, so it won't actually get to decision-making committee till October. We've set up a work stream that oversees the work, so it includes people from the CCG, but also includes people from voluntary community sector, and also Lucy as Chief Exec of HealthWatch, sitting on the committee to help really inform and shape the consultation and the engagement. I'll just take you through some of the methods. So we will be publishing the business case for everybody to read. It will be a long and lengthy document, but it will include all the financial information and all the information that people might need. We recognise that a lot of people won't want to read it, but it's there for people that want to. But we will summarise that into a consultation document. And that consultation document will be translated into key community languages. We'll also do a BSL version, and we'll also do an easy read version. And then we will do a very brief summary of that in a leaflet form as well, and share that. There will be surveys, and again, they will be translated. We propose to hold lots of public meetings, and we want to come to local area committees as well, and we'll be working with the team and the chairs. Hopefully you'll be able to find time on your agendas for us to come. And we've identified 3 local area committees. We'll also fund local voluntary community groups to get to those people that seldom heal with the greatest health needs, because we know that they're not going to fill in an online survey. So to really get to those people that potentially might be most impacted by these proposed changes. We'll also be commissioning an external company to carry out 1,000 telephone or stroke face-to-face interviews in those areas, so we get a statistically robust sample back. And they will do the analysis for us as well. So the analysis will be independent, and they'll pull all the different data sources together into one report, which I said we will share with you. Actually, one of the advantages of working with voluntary community sector groups is they know their communities, they understand what methods and communications work, so they will tailor some of the methods and use more culturally appropriate methods as well. And as I said, the analysis will come back to this committee or one of the future committees a month after the consultation has closed. So I think that will be about September time for your view. And then the decision-making committee will take on board and respond to committee's view, which will be, I think it's the end of October. I think the report does explain, so not only is it Healthier Scrutiny Committee, this is I think it's your last meeting, I understand, and the CCG is being merged into a new commission organisation called NHS South Yorkshire Integrated Care Board. And the legislation hasn't passed Parliament yet, so we don't have a firm date, but we're working towards this new organisation being a statutory organisation by the 1st of July. So they will be the organisation that are responsible for considering the consultation, considering your views, and making that final decision. So we can't come with a clear date of when the decision will be made or what committee, because that's still being worked through. So there's a few unknowns in terms of the governance. But I thought we'd be open about that. So thank you very much. I'm happy to take any questions.
Thank you. So over to questions. And I have Aptis first, and then Ruth Milsom.
Thank you, Chair. I'm going to apologise in advance because mine might be a little bit long. I read this report last night and it kept me up a few hours because it was very long, very detailed, and came at very short notice. I'm trying to sort of understand how we got to the meeting in September, and I went back and checked the minutes, to a very different proposal that's now on the table. And it might be that at that time we couldn't stipulate exactly what was on the table, which is why it was vague. And now we have a proposal which, for me, whichever way we word this, will mean the closure of 16 GP practices in the northeast of Sheffield. And for me, that's deeply worrying, because even though we're proposing new health centres, it does mean the closure of the smaller localised provision. And it goes against everything that I think we stand for in the council at the moment in terms of localising provision and making sure that communities are centred and at the heart of every decision that we make in terms of their care and their support. And I think when it comes to health centres and the proposals that are on the table, this is a service that isn't about sort of accessing shopping and being able to travel further. This is about people that are vulnerable, that will be ill, that will need localised and the support at the centre of or within their community. So for me, I really struggled reading this report, and I felt very sort of saddened by the fact that this is going to disadvantage communities. And I've not seen anything in here. I know you mentioned there's a business case for this to come through, but I don't see any evidence or information that this is going to improve the quality of care. And that might come, that might be in some sort of documents going forward, but I don't see that yet. And so all I see is a service that's going to be reduced for people with mobility issues that have less access, less ability, and it feels to me as though this has been developed without that in mind, that this, there's reference to it throughout the document that accessibility will be an issue, but some of the proposals, the overall proposals, for me, don't take that into account. And one of the key concerns that I have is that all of this is going to, the majority of this is taking place in the northeast of Sheffield, the most disadvantaged constituency in Sheffield, and we're reducing sort of the level of personalised care that's there. I understand that there'll be a business case for this in terms of consolidating numbers and making sure that there's enough numbers there in terms of patient heads to cover overheads. But for me, that's not how we should be developing our care. Patients should be the centre and core of what we're delivering. And if that's not the centre and the driving force, it shouldn't be the money and the bigger aspirations of so-called transformational centres. I really, really worry about vulnerable older people and accessibility. And as I went through all the different elements that are there in terms of the hubs and the potential places for them, we're moving things from, and I'm sure this will come out in the consultation. I'll come on to the consultation in a second, but, the elements of moving practices from roads where there's lots of public transport to potential areas where there's no public transport. Whether we're talking about Burngreave and moving it onto a side road that has a hill that needs to be with no buses there and very little parking space, to the hub 2, Firth Park, where Shire Green, we've campaigned with South Yorkshire Transport to keep a bus service there, and it's completely gone. And so the location of Concord would be very difficult for anybody who's not a car user. So those elements, I'm sure, would come out within the consultation. I think the difficulty that I have with the starting premise of the consultation is that on page 2, you say that the funding has to be used for the purpose laid out in the initial bid. So for me, what we're presenting is this is the option. You either want this or it's the status quo. And in getting to sort of whether we want this or whether we want the status quo, we then have to look to what questions we're asking individuals and communities. And for me, the questions in the initial live questionnaire that's gone forward are very leading. And giving you an example, would I want as a patient, I'm affected by this and I declared my interest earlier on. So as a patient of one of these GPs practices, the health centres, would I want additional investment in my area? Of course I would. Would I want to travel further as an able-bodied person? It is no issue for me. Would it be an issue for people who I know have mobility issues, and would they be able to access that facility? Yes, it would, but those kinds of nuances don't come out from the consultation exercise that's currently live. And then that takes me on to sort of the wider sort of consultation process. So it goes back down to the either or. We either have this and not, or go back to the status quo, and it's putting, and for me this is the ethical part of it, is putting disadvantaged people into almost a corner where they do want investment, they do want the additional resources in their GP practices because at present it's not adequate, but the only way that you're going to get that is by accepting it on our terms, rather than having a capital investment which develops existing practices and makes them better, instead of having these big multidisciplinary health centres which are just further out. So it's the ethics of that are challenging for me, because it puts individuals in a premise where it's either this or this. So I either stick with my not so good service now, or I have that, but I've got to then think about, well, am I going to be able to access that, and who can enable me to access that? So the ethics there for me are challenging as well. I feel that this is going to be very controversial within communities, and just using the ward in which I'm a councillor in, Firth Park, I fear that this is going to be very controversial, and individuals are already saying that they want to have a separate meeting to discuss this with me as their elected member, and I fear that there might be petitions coming forward about this, which shouldn't be the case. Had this been discussed 3 steps back, where you're actually working with communities to say, well, what would you like to see, rather than a new fancy health centre, which is probably 15-20 minutes walk up the hill, then I think we would be in a different situation. But I think you're putting something on the table which will be controversial for communities, and the ones who are not easily able to access the services are going to find it challenging. I'm sorry that there's not a sort of a question within this. I think possibly the question will be, how are we going to really sort of meaningfully change the consultation to allow these ethics to be considered? I can't see that that's going to be the case. I actually feel quite challenged and conflicted with this, because it's an either or. And I don't know what to do with that, because I'm already hearing from local residents that this is very, very challenging for them. That just using Hub 2 as an example, sorry, not Hub 2, the SAPA one, Hub 3, 30,000, that's a huge number. And the quality of care, are we absolutely sure that the quality of care is not going to be affected? And these are 4 very, very busy GP practices that we're thinking of consolidating. And then just the final point is and there's no reference to this in the document or in the consultation, is the spatial and the place impact, that when you remove GP practices from local areas, these become empty buildings, these become less footfall in those areas, these affect other small businesses in the area, small pharmacists, and I don't feel that that's been given any consideration. So in Firth Park we're doing our best to try and improve the local district centre, and in the local forum meetings that we've had with other businesses, this has come up, that they've heard on the grapevine, before this even was made public, that the GPs might be moving, and what does that mean for another empty building in the area and the drop in footfall, and why has no consideration been given to existing premises that are empty, that are big, like for example in Firth Park we've got a big bowling alley that's been empty for 5-6 years that nobody's considered. If it's about improving access, if it's just about numbers and making GPs all work together under one roof, it doesn't put patients at the heart of delivery and care. So I'm sorry that that's not a question, but I can only express my frustration and sort of disappointment at where we are. Thank you, Chair.
Thank you, Abtisam. That's quite a comprehensive set of comments. I'm not sure whether you want to. Would you like to comment at this point? I do have other members wanted to ask questions. So, do you want to respond at this point, or wait for other members?
If you want to take a few more questions, and we'll see if we can cover it. If there's similar views, and respond as well.
Okay, that might be the best way forward. So, I have Ruth Milsom.
Thank you very much, Chair. Firstly, I want to applaud absolutely everything that Councillor Mohammed has just said. I won't waste time saying it again, but I absolutely could not agree more with everything she said. These are exactly my concerns reading this as well. And I think, for me, this is the nature of conditional funding that we do get trapped into it has to be spent on X or possibly X or Y, and that there isn't a real choice. But again, I won't go back over what some has said. I do have further to that some concerns about the engagement, and I understand it's already been launched, so my comments are, you know, maybe speaking into the air, but I feel it's not absolutely clear enough that this is talking about closing practices and moving them to new buildings, that existing services will disappear from people's locality. I don't think that's actually clear in this engagement, and I think that's a big oversight. It may be that there's some text that is live on the online engagement exercise that I haven't seen yet, but what's given to us here in this report is that's not clear. It would be clearer to say we've been awarded 37 million conditional money to transform GP practices. It must be spent on building up to new 5 health centres which relocate existing neighbourhood GP practices under one roof. It really should be clear, this. So I find that quite a bit concerning. And I mean, already one person has spoken to me about it just off the cuff and making an assumption that this sum of money, 37 million, investing into GP services must automatically result in more GP hours, and that's not specified anywhere in the report that we're going to anticipate more hours or more GPs in these practices. So I really want to flag that up as a big concern. It should be clear as well, I think, that the status quo will be a final option on each of these. So where it says no decision has yet been made about whether these plans will go ahead, we'll keep you informed. I really think there it should say that the status quo will always be remain an option. Otherwise people are just being led towards commenting on the potential change without realising that they needn't accept it at all. And then the questions aren't numbered, so it's a bit difficult to go through them, but so the first set of questions that begins, my GP practice site provides a good environment for healthcare. I find the second question there, more investment is needed in my GP services in my area. I find that an awkward question because the large majority, of course, are going to strongly agree. Who's not going to turn down investment? So I would seek some assurance really that the response to that question is not going to be directly translated as support for the scheme, because the scheme is very specific about how the money is spent. So generally asking about investment and then using that as indicating support for this scheme, that doesn't correlate at all for me. 2 questions further on, building new GP health centres is a good idea. So here, I find this question a bit misleading as well. Of course, most people will say building new GP health centres is a good idea. And a lot of people will see that as, oh, we're going to get additional health centres, which isn't the case, reading between the lines here. So that question fails to make it clear that a new health centre replaces multiple existing neighbourhood located ones. And I think that's actually very poor, to be honest. I do find that misleading. The inclusion of that question without an explanation. The question really should be building new GP health centres to replace existing neighbourhood ones is a good idea. And I think you get a different response. Later on in the engagement, bear with me because I'm working online here to try and save paper. Sorry, bear with me. I'll go through all the maps. There's a comment later on. Here we go. So again, the questions aren't numbered. So it's the first section after all the maps, I think. If your GP practice was to move to one of those new sites, how do you think the following things would be? And this whole section I find very awkward. Because outcomes of all except question 1, which is travel, getting there, would you find that much better, no difference, worse or much worse? all accept that question in the engagement, how can people possibly know until the centre is built and they've seen it and they've tried getting there? So you ask about waiting areas, would these be better or worse? Access to additional services, better or worse? Care provided by your practice, better or worse? Accessibility of the building, better or worse? Size of the building, better or worse? Accessing care in a modern building, better or worse? Well, you'd hope better, but you can't assume. So the answers to all of those questions is impossible to say. No one's even seen a plan for a building, let alone been to it, or let alone accessed their GP services that they know now in a transformed setting in a new practice. Those questions are impossible to answer, and I really hope that either positive or negative responses to those questions won't be a big influence in the outcome of this engagement going forward, because they're really, I mean, maybe I'm being a bit dim about it and you can explain to me how those questions are useful, but if the building isn't there and the services haven't been moved into it, how can anyone predict what they're going to be like? It's just pure speculation. And then the following is, what are your thoughts about these plans to potentially build 5 new GP centres? Again, that's a bit misleading in that, again, it doesn't specify that we're not just building 5 new GP centres, but we're replacing existing centres with a more centralised location. So again, a very leading question. And so I would hope that responses to that won't be taken as, you know, heavily weighted towards wanting the plans to go ahead. The following one, what do you think about the following elements of your current GP practice? I do think the other 2 questions that are included in the speculative section before should be included in this. There are 2 questions that aren't in both, which is care provided by your practice and size of the building. Some people might feel quite positive or negative about those things, and those 2 questions seem to be omitted from that section. And I think that's the end of my comments. So, sorry, that's entirely negative, but that's genuinely how I feel about it. And we have kind of been here before with consultations about all sorts of things in the city, and it's incredibly hard to get an engagement exercise right. Obviously, you could end up with something that's just too unwieldy for people to handle, and you wouldn't get any responses. So I do understand that, but I really do have to press that forward. I think it's leading and misleading, and I have concerns that the responses to what I think are poor questions will inform the next stage inaccurately. Sorry.
Thank you, Ruth. I'll move to Alan Hooper, and then I have three others, but I'll come back and see whether you want to respond to after Alan's.
Thank you, Chair. I can appreciate previous dual councillors' comments about issues and many issues, but there is there £37 million investment into Sheffield and health services. So I think we should look at the opportunities that are available. It would be sad if this didn't go ahead in some form or other, perhaps not how it is now. I appreciate what you've said about the travel, and we had that with dentist provision earlier, people having to travel. We should be looking for local services, especially with COVID and travel and fuel prices. I can appreciate the travel because in the north, where I am north-like, travel to children's services includes 2 buses, and it's virtually impossible for young mums with prams to get to services, so I can appreciate that and they need to be local. I have 3 questions. One, what happens if practices don't want to join the scheme? Will that make it reduced? If they don't want to keep working as they are, will they still get funding? The opportunities with the new hub, would there be extra additional services in there, such as dental services, diabetes services and stuff like that, minor ops, I think that they do that at Fairlawns. And when practices move, will the patients be able to retain their own GPs? Because we're talking about 20,000 plus, and if it's going to be a number of GPs, can we try to look at where existing practices can keep within the major hub their own patients? I've got experience of where we've got a surgery with perhaps 6 doctors, and I think it's much better if you can go within perhaps that number or even less, and if people can see a doctor, if they've got long-term issues, the regular doctor, they know your case and know you. So I think it's just the face-to-face, but yeah, it's a major challenge, but and there's not a lot of time to do it, but I do hope the consultation can be sort of addressed in a positive way. Look at the positives. There are negatives there, but look at the positives. Thank you, Chair.
Right, would you like to have a go at responding to quite a large volume of comments there?
Absolutely. So if I make a start and then Lucy come in specifically around the consultation. So just in terms of where the proposals came from, so it came from practices looking at the constraints that they have in delivering services at the moment. So we have lots of really amazing practices, but they are really constrained about what they can do in their current premises. There has been small amounts of investments over the years to expand premises where they can, but the practices were coming together to look about the fact they didn't feel that just expanding within limited resources. So they put forward the proposal about if they came together, they could provide services for their local populations, but additional services compared to what they could do now. There are also issues, particularly in the north of Sheffield and in the more deprived areas, of attracting GPs and other workforce into those practices, which limits their ability to provide access because they're constantly trying to attract people to come and work in these difficult areas. One of the barriers that's been put forward is actually having to buy into a practice, particularly in deprived areas where there's potentially negative equity. So they were looking about whether there were opportunities, if we could attract capital, to actually address a number of the constraints that they'd identified. There is always a balance between having very local accessible services that people are used to and what potential changes could mean. For some people that might be better, but for other people that might be worse. And that's through the pre-engagement and the consultation we want to understand further what those issues are. But there are some real massive challenges in these areas for delivering primary care services, and the practices came together to put forward what a different way of doing that is. So I absolutely accept, Ruth, that there are very clear conditions in terms of this funding. When the initial bid went in 2016, it was just left, nobody picked it up, and it wasn't until the government announced some additional funding linked to the Modern Hospitals programme that somebody somewhere in the Department of Health identified this as an opportunity, but it was very much about investing in bringing practices together and wrap-around services at scale. So that's the basis on which the funding's been awarded. And we have to work within the constraints of the conditions of that funding to be able to deliver some of this. So that's why one of the options is that if we can't make this work for practices and the populations, the status quo might be the only alternative. But we can't just decide locally, well, that's not a goer, so we're going to decide to just invest it in individual buildings, many of which we can't expand anyway because they're not capable of being expanded. So lots of challenges here, and I think what we've tried to describe in the engagement and then the subsequent consultation is that we're trying to understand what people's views are about that. The opportunities around bringing in other services that might be less accessible at the moment is one that we want to explore as well. But it's got to be practical to bring those services in as well. So dentistry, I must admit we haven't had a lot of conversation about dentistry. That could be one that we look at, but it will involve working with NHS England to look at that. So I think, I don't know, Lucy, if you want to come on to some of the questions around consultation, then we'll come back on to the more specific questions.
Yeah, some of the points about the evidence for improving care and reducing health inequalities, that will be a huge feature of the consultation in the case for change, and we realise it's not in the paper,
But yeah, so we can't expect people to share their views unless they understand what the benefits or actually disbenefits might be. So that will be a huge feature of the consultation. Some of the points about this engagement survey, so thank you very much, actually, you've made really, really good points. I will come on to those, but I think just to emphasise that this is the survey for the consultation we're carrying out now. It's not engagement, it's not the consultation survey, so that will be very different. We can quickly make some amends, actually really good point, it doesn't mention relocation of premises and closure of premises. So yeah, hold hands up to that, that's a major omission, so we will get that in, that will be front and centre. And one of the other things we're hoping to explore through the engagement is people's suggestions for other locations, because actually you said, Councillor, about the bowling alley. Actually, we might not have considered that, or it might have been on the long list. But so we want to find out what locations there might be in areas that either we have considered or haven't considered. And as part of the consultation, we'll be very clear on all the locations that are being considered and why they've been ruled out, so people can understand that actually every little bit of land or unused building has been looked at and ruled in or ruled out for whatever reasons. Councillor Mohammed, your point about you actually said that you would answer as an able-bodied person, but we haven't got the nuance about people that maybe aren't able-bodied. And we're hoping that through the demographic questions, then we can disaggregate by protected characteristics, so we'll understand the views of people with a disability, for those able-bodied, and that would actually help shape some of our thinking. And around the questions, I think for me and the programme team, there are two key questions in this engagement that will shape the options that are going to be appraised, and actually we want to work with patients on appraising those options as well that then are presented to consultation. Are, what do you think of the locations? That's fundamentally a qualitative question. What do you think of that location? And that will draw out all sorts of issues, or hopefully people might like them as well, and ideas on services, because we haven't bottomed that yet. We don't know what those wraparound services are, so it would be really good to understand what would be helpful to the public. And from the reducing health inequalities point of view, that the evidence is that even though patients might be travelling a bit further for their primary care, actually if you have those wraparound services, it can have a big impact on the health outcomes. For example, if you co-locate mental health services, GP services, and say debt advice in the one building, then people with mental health problems who are struggling financially might all benefit from getting input into the physical health, mental health and debt management all at the same time, improving their health outcomes. So that's the sort of basis and thinking around that, which will all be a big feature of the case for change. And actually you have raised some really good points about the engagement survey, and a part of the consultation we want to have a readers panel working with the public, and we want them to say actually the language isn't right, actually your question is a bit leading. And so we do want the public to help us with that, and I wondered if some councillors might want to be involved in some sort of readers panel. I mean, actually you sound, you've got a lot of expertise and some great views, so if you're happy to be involved, we'd love to get you involved, probably around May time. So yeah, probably just after the elections leading up to consultation. And we will pilot any consultation surveys as well, and working with an external organisation with that sort of expertise and fresh pair of eyes, which for this engagement I think we're all so close to it that yeah, we've missed a few things. So hoping that's covered broadly a lot of your comments. But take any more.
Sam, you made a point about the local area committees. Can you just repeat what your point was?
Well, it was about the involvement locally. I think it was the discussions locally. I can't remember what the question was, if I'm being honest. But I do have a follow-up, if that's all right, Chair. Yeah.
Go ahead.
It's just in terms of is there an alternative, or is it only these 5 centres? Like, is there an option of several within each of the different boards, the constituencies? Because I think the thing that's alarming me most is practically everything in the northeast, all of the GPs are going, and we're left with 5 big health centres, but we're losing the small ones for the vulnerable patients. Is there not a middle ground here where you could develop several in some of the wards and not lose, or is this about numbers and finances as well? Is this about you know, it's not financially viable to have two in some of the areas. So Shire Green and Firth Park it's a very big area, and you know, and Parson Cross and Southie, huge areas, and we're just having two across that patch. Is there not the possibility to think about, well, how do we increase the numbers here, taking into account accessibility is going to be the fundamental issue here, so that the patients of Shire Green are not going to lose out, patients of Firth Park would benefit equally from, because I think it comes back down to what Councillor Hooper said of not losing the money, but it being a benefit, a real benefit to local people. And you know, is there any flexibility there? Is there any chance that we could sort of push on several rather than just two? Could we not double it?
So shall I come back in on that specific? And then I am conscious there's a couple of Councillor Hooper's questions that we've not answered, so I'll come on to that in a moment. So I'm trying to think of something more political than no, but I can't quite say. The funding's been allocated on the premise that we're bringing together services to provide more at scale and wraparound services and other things that we can do. So it isn't driven by money per se, as in, you know, we have to make a saving. It really isn't, but we have to demonstrate value for money, and the spending objectives that we have to demonstrate we meet, one of the key ones is about bringing together services on a wider footprint. There is a government direction of trying to get practices coming together more at scale because they are, frankly, more sustainable, because we have real challenges in terms of small practices actually being sustainable at the moment. I'm trying to think in terms of a number of the options. So what we've pushed for, and probably, I feel we're probably at the limit of, we've pushed for these to be a smaller number of practices as we can make them be, because if you look at some of the national direction, there's a national news scheme around what they're calling Cavell centres, and they are bringing together practices at a population of 30 to 50,000 big multi-practice centres. These are seen as quite on the edge of being smaller developments, so whilst few locally these feel quite big, actually in the national context they are quite small. If we can't proceed with these, the funding initially goes back into a South Yorkshire pot, and there are a set of alternative projects that are already on the reserve list. So I think the first option would be to put in more investment into Doncaster and then Barnsley. And then if we can't demonstrate delivery of those, it would go back to Treasury. So there are lots of conditions around how we use this funding, which is why we're keen to see whether what we've put forward would work for populations. And the site selection, so the GPs and the council have been heavily involved in all the options around site selection, and practices have been really mindful about not saying they wouldn't want to go too far away from their existing locations, precisely because they don't want their patients to travel too far. So the options that we've put forward are trying to limit the amount of distance from current locations. But part of the consultation will be around where are those practices, registered lists, where's the distribution of those populations, and what does it mean for them?
I think Councillor Mohammed asked about whether, I think I understood that, do all practices have to move into the hubs? So it might not actually be all 5 practices, it might just be 2 or 3 that move in, so that are currently being proposed. So those practices are exploring the benefits to them as a practice, and they're going to take on board the views of the patients before they make that decision, before either they want to continue as part of the consultation or actually want to sign on the dotted line after the consultation. So it might not be all those practices that move in if the health centres are actually built.
Yeah, sorry, Ruth Milson, do you want to come back?
I do have just a follow-up question, if that's all right. Sorry, I did touch on very briefly earlier when I made my other comments that it's not mentioned in the report that these plans would result in any uplift of GP numbers or hours available to patients. Can you comment on that? Is there an expectation that this will be an uplift overall, or that in terms of you know, available appointments, GP availability, will it remain the same? Is that the plan? Or if the net result of practices moving into new premises is that there's a little dribble away of, you know, there's some natural loss of people when they retire, or they decide to retire early, or, you know, they can't be bothered with the whole upheaval of moving practices, so they might just, you know, take early retirement. So the natural wastage, if you like, is there an expectation that the status quo, at least, of availability to patients will be maintained, or even better, an uplift?
Yeah, so there is an expectation that at least the status quo would be maintained. What we have through the National GP contract is the opportunity to employ additional wraparound staff. So people like link workers, pharmacists, mental health workers. A number of practices are struggling to find locations for those staff. So whilst they can employ the staff, they haven't got room to actually put them in. So the expectation is that they can get these staff co-located within the new proposed health centres, which should expand access for people. And if we can retain and attract GPs to work in these more deprived areas, hopefully that will have an impact on access as well.
Sorry, thank you, Chair, for indulging me. Sorry, just one more follow-up. Would there be a viable scenario where a new hub is built and it houses all of the extras that you're talking about, but none of the GPs? Would that be a potential outcome, that you could have a health and well-being hub that would be extremely comprehensive and include, you know, help for access to food, help with life skills, even how to brush your teeth, to go back to our earlier conversation, and the debt advice and things like that you're talking about, and the other wraparound healthcare things like physiotherapy and eye health and things like that? Could those hubs house those things but not the GPs? So you could end up with none of those practices actually relocating at all, but still getting the hub.
It has to be a GP-led building, but I'm intrigued to see how far we might be able to push that. So I can't give you an answer today, but it's an interesting concept to explore. So we'll note that. I am conscious there's a couple of Councillor Super's questions I haven't responded to, if we just want to pick those up.
Yeah, let's pick those up. I have Ruth Mercereau, Lucy Davis and Gary still to ask questions. Okay.
I think these are relatively quick. So you asked about what happens if practices don't want to proceed. So practices don't have to proceed. It will be a judgment that they make, both around the feedback on the consultation, but obviously they need to make the decision for themselves as an individual practice. But yeah, as Councillor Mohammed's mentioned, you know, it's not an option in terms of thinking that we can just develop the individual practices themselves. The extra additional services as part of the engagement and the consultation, we want to understand what people struggle to access and what could the alternative services be provided in these local areas. So there is absolutely the cases around if we can make more of those types of services accessible and reduce barriers to access, that will hopefully improve the health outcomes for these populations. In terms of will patients be able to retain their own GPs? Yes, so there's no proposals that the practices would merge, so the practices would still be individual practices just within the same building. And I think it's important that those GPs have their own practice identity, and I think they would be looking to maintain that. They may choose to share some back office functions and be more efficient through those, but there's no proposal that we would merge the practices.
Okay, Ruth Mercereau, yeah.
Most of my comments were covered really well by the councillors, but I've a couple of further comments. One of which is in the travel survey, cycling is not an option, and I was wondering why not, particularly as we need to get cycling embedded in terms of its miracle pill effect on people's health, and also as bikes are often mobility aids for many people. So that was something that I really wanted to put across. You asked for suggestions about who to reach in the consultation. I'm a City Ward councillor, and I'd suggest that for City Ward, contact the residents group, so Changing Chef for the city centre, Kelham Island and Neepsend Community Association for Kelham Island, and St Mary's Bramwell Lane Church and Community Centre would be a good way of reaching more people.
Just quickly come back on the cycling, yeah, that was a mission. But I say, when we come to do the consultation, you know, it will be go through readers' panels and piloting, so we'll pick up any omissions like that. So, yeah, apologies.
Yeah, because in terms of cycle parking as well at hospitals and surgeries, it's really lacking, and it stops people from travelling that way. Thank you.
And we'll add those residents groups as well, so thank you.
Okay. Lucy Davies.
Thank you. Again, I think lots of my comments have been picked up by other councillors. I do want to emphasise, as Councillor Mohammed did, that this proposal does go sort of contrary to what we generally hear from the public in terms of what they want from their care. So that message of generally people want care that's closer to home and local to them is kind of, I guess, at the top of my mind as we approach this subject. But trying to put that aside and think about the opportunity to sort of talk with people and explore whether this could work for them, which is clearly something that we need to approach sort of positively given the potential for investment. I think that the plan for the consultation phase, I think it's pretty robust. I think people won't understand that what's happening now isn't a consultation. And actually, I do feel slightly frustrated that we're missing an opportunity here for a proper dialogue, because we're not starting from a good point. We're starting from a plan that's been brought together by GPs themselves some time ago, without, I think, as far as I know, the involvement of the community and of people. And I think that the backstory is missing for people. So you've described things here today which actually I didn't understand. I was like, well, actually, I didn't know that they'd already had conversations about the constraints that they were under. I, as a patient in one of these surgeries, actually, when I reflected on it, I thought, I don't know what's missing, that this sort of, GPs are sort of not able to provide in the current setup. And I think people deserve to properly understand that information. So I agree with everything that Councillor Milsom said about the survey. I think at the very least there should be an option that says for each question, not sure, I need more information. But actually I'm not sure that a survey at this stage is even the most helpful thing. I think a dialogue, and I think I've raised this in some of the meetings, Lucy, I think that idea of opportunities for people to sit and hear about the sort of background, the context, and the sort of ideas behind this, I think would actually be would feel like a much more useful thing at this stage. Alongside a survey potentially, but I think that's what's missing at this moment in time. And now is that opportunity to do that, because once we get to consultation stage, the options will be narrowed even further. So then, it doesn't matter how robust that is, you've already taken away some of that opportunity for people to influence. And I guess that's my concern. Is there anything more that we can do at this stage to widen out people's understanding, the information they have, and to be able to meaningfully contribute to this discussion? Thank you.
Thank you. Can I come back there?
Yes. Sorry, and I must say that Gary has to be the last one because we're starting to run out of time. Okay.
Yes, thanks for those points, Lucy. We are trying to organise some public meetings, and if possible, I know we've got one chair here, if we can come to a local area committee this time before the election. And we do want to set up public meetings, and if any councillors know of any that we can come to sort of, in March, April, then yeah, we will set some up, because yeah, I think that is really important about a dialogue. And we haven't actually done the big launch of actually, it's exciting, we've got this money, these are the sort of things that we might be able to do with it. What do you think? Because we haven't had that a confirmation from the Treasury until last night. So now we've got that, we can look at actually doing something and really trying to get, you know, this is what it means, this is what it doesn't mean, what do you think about it? So using the media and through public meetings. So yeah, we're going to work on that through March and April. Obviously we can't do any communications, big communications through April because of the pre-election period, but we can continue with public meetings and things. So yeah, thanks for that, Lucy.
Gary.
Yeah, thanks, Chair. Thanks for coming. And I appreciate it. Treasurer's only just passing through to yesterday, and we've got this information overnight to read and take in. And it's not sunk in to me, because I think what we've got to do is do the consultation first, in my opinion. And I thought, I've been on this board from day one, from it starting off 20 years ago. And disappointed, yes, but £37 million for City, I'm happy with that. There's a lot of work to do though from now on. I thought we were looking at the buildings, because the GP's buildings after the war, they all set up and they bought an house and set up in front room. You know, that's where we are. And I do like the, you know, these hubs coming together, nurses, doctors, dentists, you know, other organisations like debt recovery and things like that. So that I'm really excited. I better inform you that I'm local area committee chair for these 4 wards where all this is happening. And, you know, we're going to, I've got a card here to give you with contact details of my manager and staff. And I think we need to get ASAP, get a meeting up between us all and members as well. So that'll be coming in if you can get in touch with them. But I'll leave you this card so you can get in touch. There's a lot of stuff. I mean, you've got down consultation with lots of stakeholders, but not Shire Green Tara, which you put it down in page 9. You skipped it on there. And I've got to register my declaration of interest, Chair, because I didn't realise Margison is a branch of Ecclesfield Parish, Ecclesfield surgery, where I'm a patient there. So it is. I'm not going to dwell on anything. I mean, Abdisan and Ruth have put a lot of things in. You know, it's not going to be a comfortable ride, and it certainly isn't. But I can see where it's going to be. People from Duncan Surgery and bottom end of Shire Green going right over to Concord Park, it fills me with dread, really. You know what I mean? And then, you know, so I'm just thinking out loud, that where we've got offices on Shire Green, Tara and other places, where we might be able to have a talk with you to see if we can do a satellite, you know, 1 day a week and doctor turn up there with appointments and things like that. I don't know, it might work, it might not, but at least we're going to chuck that into ring and see if we can do that. And maybe we've got a few places in Firth Park as well where you can do that type of thing as well, and Burn Green. So not going to chuck anything off. I think everything's going to be on the table. I think you've done that in your report. And like I said, 30,000 going to be in that new hub at ours. It just, like I said, fills me with dread. But at the end of the day, you know, where doctor surgeries at the moment has got 15,000, 16,000 members, you can't get an appointment now. You know, so you can get 30,000 in. You know, I know all GPs are going to come together, but there's still a lot of work to do on that. So I'm going to stop ranting, Chair, because we've got a lot on. We've got another presentation after this, but if I can give you this card and then get in touch with managers, and we'll set a meeting with all local councillors as well.
Okay. Right. Is there anything I want to say in response to you know, to round up? I mean, we'll come to the recommendation. Sorry, let me chat over to you. Anything you want to... No. Okay.
No, I think just thank you for the comments that we've had. They've been extremely helpful.
I'll pass over to Emily. What are the recommendations? Remind us what the recommendations that for us today, members.
So in the report, you're being asked to consider the report and approve the consultation plan. Having listened to the conversation today, I've been trying to pull together a possible resolution. So perhaps noting the report and the consultation plan, requesting that the CCG takes on board the committee's comments and concerns made today and uses them to influence the consultation and engagement activity going forward, and looks forward to considering the outcome of the consultation and the case for change later in the year. Does that...
I'm conscious that things will change after May. Can we not have something that brings back the interim consultation? I'm just a bit concerned that we wait until the consultation is completed and we don't see anything that's happened. So is there no interim that we can have a summary report that comes back to us?
Okay, and ask the CCG to keep the appropriate committee informed of progress during the consultation period?
Possibly, but I'd also like to take, is it Lucy, your option of involvement of councillors in the process as well, to be included in that, but an interim report, so sort of summary as to where we are with the consultation, not waiting until the final report to say, here we are. I think it would be useful to see how the consultation is going, just in case it's all completely negative and they decide that it's not feasible at all, rather than wait until the end point, we've got some interim understanding of what's happening.
And that report would come to the subcommittee. Just clarify whether
it would procedurally. I just wanted to check with the CCG whether that would work in terms of, would you be able to provide an interim report, or would you have to wait till the end? Yeah, okay.
Yeah, of course, yeah. Well, we'll work around you. I mean, if the engagement hasn't finished at that point, we can share what we have now. If it has finished, we can share everything and then talk you through how we're approaching options appraisals and readers panel and that sort of thing. Yeah.
Just on an operational issue then, how are we affected by PERP in terms of our involvement in the consultation locally as councillors?
I think from our point of view, we would probably have to invite the prospective candidates as well.
Yeah, okay, to any public meeting?
Yeah, I think so, yeah, for us we would, yeah. Yeah, before May, yeah.
I can ask the monitoring officer to confirm anything, but I think it would be unlikely that we'd be looking at council-led meetings here, so it might not be an issue. I'll need to check.
In terms of community events, so I can anticipate local residents requesting a public meeting about this. So if there is, between now and May, a public meeting, I'm just thinking about what that means practically, with other candidates having to be there.
I think if it's a public meeting, we'll just promote it broadly and through community groups, and whoever comes, comes. But if we're doing something specifically with councillors, and as a CCG, we'd have to invite prospective candidates as well. But if it's a public meeting, then not necessarily, no. Okay. We'll just promote it. Yeah.
Okay, so I'm clear about that. Gary? Yeah.
It's clear that, Chair. If you have a public meeting, I'm chair at like I told you, so I'll be chairing those public meetings. But the thing is going through us, and you having regular reports back to us. That's what we'll be asking for, you know. So that'll be going to all members, because this is not going to go back till this won't be coming through to committees till June, maybe July, you know. But we want to be right involved from the day one. That's what I said. If you get in contact with our manager, we'll set something up ASAP, because it's going to affect us all. All right. Thanks so much.
Okay, so we agree that that's the recommendation. That's what we need to put out. And can I thank you both? Thank you both for attending today. Okay. I'm just waiting for Emily to come back before I move on. I'm lost without her. Okay, colleagues, if we can move on to item 9, would you, Alexis, would you like to introduce yourselves? But I think most people know you, but everybody else. Okay.
So thank you very much for today. My name is Alexis Chappell. I'm Director of Adult Health and Social Care, and I'm going to introduce Liam and John.
Hi everyone, my name is Liam Duggan. I'm Deputy Director of Governance and Financial Inclusion in Alexis's Adult Social Care Service. I'm sorry I haven't got a name badge today, I'm a late entry, covering for somebody who's not able to be here today, and who has done all the work as well, John Higginbottom, so apologies for that.
Hi, and I'm John Brenner. I'm Principal Programme Manager within Adult, so I'm part of Alexis's leadership team and I manage the change programme.
Thank you. Okay, so we have 2 reports. So I'll hand over to you, Alexis, shall I? Okay, introduce first and then, well, however you want to do it, play it.
Thank you very much for the opportunity today. What I thought we could do is introduce the first report on the inspection preparation and then take questions and then move on to the next report, if that's okay. So first of all, in terms of the inspection readiness, I just want to say first of all, thank you very much for the opportunity to discuss the report today and for inviting us along today. As a context, the Health and Social Care Bill brings and introduces an assurance framework for adult social care and system partners, particularly across the ICS and at place. And for adult social care, one of the key things for us is to be absolutely prepared for that assurance framework coming into place. And we reported back in November the development of the assurance framework, and we said we'd bring back a report with more information, so here it is today. And what we're going to do is give you a very brief update of the emerging framework, but also practically what we're doing within Sheffield currently, and ultimately what it means for people. And I would just like to say at this juncture is a couple of things. Number one is that we very much see this as an opportunity for quality improvement and involving experts by experience and people with lived experience and their family members, ensuring that we deliver high quality personalised services within Sheffield. And we see the assurance framework as a really great opportunity for a catalyst for change. And secondly, we just want to take this point to thank John Higginbottom and Nicholas Scott, who are officers within my team who are doing a huge amount of work to not only go and support the preparations across our teams, but also system-wide with system-wide partners. And finally, on my workforce within adult social care, who have really, at the time of the pandemic, have really embraced the continuous improvement framework that we've introduced as along with this. So on that note, I'm going to hand over to Liam.
Thanks, Alexis. So the presentation today, as Alexis mentioned, if we can move on to the first slide. We're going to have a little look at the emerging single assessment framework. Details just starting to emerge from government. The progress update on the work that we've been undertaking over the last several months, and next steps, and finally what this means for the people of Sheffield. I'm aware some colleagues are some way away from the screen. I've got a hard copy of the presentation, if that would be helpful. Okay, so firstly onto the timeline. Lots of engagement taking place now between the government, the LGA, ADAS, and local authorities. We're looking to get detailed piloting methodologies taking place, starting over the course of the summer. By August, the CLG are looking to sign off the approach, and come April next year, the new arrangements will go live. The new arrangements are in order to do 2 things: to establish a baseline understanding by the government as to the quality and safety of adult social care provision, and to develop data sources to support that ongoing assessment. think it's important to say that because of the arrangements that have been in place to regulate adult social care over many years, the CQC are not starting with an established comprehensive baseline understanding of quality and safety of adult social care. And so one of their key priorities is to establish that baseline. Also, CQC looking to remove the distinction between monitoring and assessment and move away from inspection as being the only means of making judgments. So we're moving to an ongoing assessment of risk, quality, safety. And lastly, only making use of physical visits where that's the best method of gathering evidence. So a slight departure perhaps from some of the other regimes that we might be familiar with. And we understand that they're looking to move away from a reliance on inspection and one-off data requests as things progress. So if we move to the next slide, we can see the emerging framework and what that's starting to look like. The 5 key questions at the top are consistent with the key lines of inquiry, the 5 key lines of inquiry that the CQC are already using to regulate provider quality. So that's safe, effective, caring, responsive and well-led. They'll be incorporated into the framework as the 5 key questions. Underneath the 5 key questions, there are a series of 9 quality statements reflecting the Care Act responsibilities and in line with the 5 key questions above. Now, each of those quality statements will be graded 1 to 4 from outstanding to inadequate through this process. And then down through the pyramid into evidence and specific quality indicators. Useful to note, I think, that now that the ICS is all but statutory, it will be from April, this framework for adult social care is effectively a single quality assessment for local health and social care systems. It's an important point, I think. If we go on to the next part, please. We've got 4 themes emerging, so key questions, quality statements and themes. Each will have and contain within them 4 the key questions and the quality statements, and each will describe a basket of evidence that the process will evaluate, including people's experiences, processes, feedback, outcomes and performance data. The next slide attempts to bring that together so we can see the 4 themes emerging. Each of the 9 quality statements and how they sit within the themes, and also not included on here, the 5 key questions. The first band is effective, the second band down, how local authorities provide support includes responsive and well-led, and then the third band is safe, and then the last band is well-led. So an attempt to show how the we statements, the quality statements, will be banded into those themes. So that's pretty much what we know about the emerging framework at this point in time. What is the council? What are we doing in response to that? Well, we're not preparing for an assessment visit. We are establishing and embedding a governance structure within adult social care, which includes within it arrangements for performance and quality, culture change, and driving continuous improvement. The next slide shows the 5 key elements really around the work we're doing within adult social care governance to drive performance and quality. The top 2 boxes, practice quality standards and care quality standards. These are pieces of work that have been co-produced with staff and people who use services, which describe what good looks like. What can people expect from adult social care, and how do we drive improvement in quality practice? The performance improvement framework on the bottom left is how we are assured we're moving in the right direction. The framework is the bit that holds it together. It links our strategy for adult health and social care and the regulatory requirements, which we'll see through this framework once it's finalised. We'll link that to the outcome measures that will tell us whether we are achieving our ambitions, and under that metrics, volumes, timeliness, cost and quality, and how they link to the quality frameworks and what good looks like. So that performance improvement framework, the bit that holds it all together. We've also got a series of performance clinics which have been established, which is the process by which we drive that culture change, that performance improvement. And that's the conversations with staff, with people at all tiers of the organisation. So we have a collective understanding of where we are and where we want to be. Quickly, progress update. We have an agreed approach and methodology for inspection readiness. We've been using the 5 key lines of inquiry from the CQC and the Care Act as a framework for that. We've, over the course of late summer and into the winter last year, extensive workforce communications and engagements in different formats, lots of well-attended drop-in sessions for staff to come along to. We've then gone through a self-assessment process using a tool that's been designed for that purpose within teams, and they are currently in the process of feeding through into performance improvement plans for each service level, which in turn will feed the change programme and our performance dashboard. We have developed a case file audit approach and methodology for driving quality. As I mentioned, we've got new practice quality standards now in draft going through review, and we're also working with system colleagues, partners on driving improvements at a system level. The next steps, we're close to the end of phase 1 now, where we'll have performance improvement plans for each part of the service that will be then embedded into the change programme. The next phase will be to work from that, to use the processes that we've established to drive improvement, get started on moving those metrics in the right direction, and ensuring that we've got a performance improvement happening at each tier of the organisation. We're then planning to undertake an external assessment of some sort, get a second opinion on where we're at, and then the phase 4 will be another phase of improvement prior to the new arrangements nationally going live from April next year. It's been a conversation about inspection readiness, but I think as hopefully you'll be able to see, this has been a catalyst for change. We are embedding a culture of continuous improvement in adult social care now. And the arrangements that this brings, together with other changes around joining up care for people, places and populations, will allow us to work in a more integrated way with our health partner organisations and voluntary community sector organisations to improve outcomes for people in Sheffield. Okay, that's the presentation. Welcome questions.
Okay, thanks, Liam. Okay, over to members. I can't see anybody indicating. Lucy.
Thank you. I think I'm going to ask what's probably quite a predictable question, which is that although it talks about the assessment framework sort of being linked to I statements from the CQC, what I don't really see in this paper is explicitly the point at which the views of people locally will feed into this process. And I think maybe you've done yourself a disservice, because I know that there are some things in the pipeline to make that happen, but it's not here, I guess. So I just wondered if we could sort of be a little bit more explicit about where and how people's views will be captured and fed through to the different elements that you've just set out. Thank you.
Just come in here. So Thank you very much, Lucy. Really excellent question, and I think you're right. Upon reflection, I'm realising we've not noted all the work that we're trying to do. One of the key things that's absolutely core to our change programme and to the changes in the culture in adult social care is making sure that people's views and voices are absolutely central to what we do. And there's a few practical things that we've done to that end. Is number one, establishing a citizens board as part of our overall governance arrangements within adult social care. And one of the key things for that, for me, is really important so that people's views are absolutely central to how we go forward, and people's views are very much seen as experts by experience in telling us about the quality of services that we both deliver internally but also commission across Sheffield. So very much that's absolutely under development, and we currently have some experts by experience currently in place, and our plan is to absolutely go and expand upon that as we go forward. And so that very much develops in part of the performance improvement framework. And then the second key bit for me is around how we also involve unpaid carers. And we've just recently re-established our framework for supporting unpaid carers, and it's really important that we work with colleagues in the VCF and unpaid carers to ensure that unpaid carers' views are also absolutely central to how we go forward. And that's also going to be taken through our new governance arrangements, because I always have a view that you could have the best performance, green in the world, but if people are telling you that their experiences are not that great, then ultimately that's what you've got to listen to. So that's where, for me, what's been really important as part of our change programme and also part of this development is that we've established these formal arrangements in place. And what I'm going to do is take on board Lucy's advice and ensure that it's actually drawn about and drawn in within both the work that we're doing, but also it's really highlighted and demonstrated. So hopefully a good piece of practice in going forward.
Sorry.
Yeah, thank you, Alexis. So I think that's great, and I think that involving people with lived experience in the governance structure is a huge step forward. I would say that potentially what you sort of didn't really touch on there so much is, I think, what social care kind of slightly behind the curve in terms of that routine collection of feedback. So in the health service, you've got friends and family tests and different things that are embedded as a really routine mechanism, and I don't think anything like that exists currently. So I was wondering about that sort of, yeah.
Yeah, really good point, and it's a really well made point, because it's something that we discussed when I came into post, and we've taken that on board, Lucy. And I'm going to hand over to John, who could perhaps give you the answer and the good news.
It's a good point and well made. We are currently scoping out what something similar to the friends and family test would look like in adult social care. We'll talk to you more about that as the details develop, but it's certainly very much on our mind. I think there are other elements of routine feedback that we are working to be smarter about using. So actually we hear things from people we're working with every single day. We hear them through our complaints, we hear them through our everyday interaction, our regular engagement forums, etc. And we're putting in some mechanisms that I won't go into the detail of now to ensure we are tapping into that really rich qualitative feedback that we're getting from people on a daily basis, and make sure we're building that across our change programme, not just in the kind of the compliance space, but actually in terms of our driving through the delivery of our overall strategy around our aspirations and our ambition, not just our base level of compliance.
I think the other thing is, instead of us having a system-wide body, a group, what we're trying to do with the culture change thing is devolve it down to teams, and so that each individual across the organisation understands the feedback that they're getting, that they're making use of the contact they have, that is being discussed at a team level, not just at a committee level or whatever, but at team meetings and peer review. We're evaluating complaints, we're making use of each of the contacts that we've got, and that's informing a view. It's not just us, it's everybody in the organisation has a view on how well we're doing and how does that compare with where we want to be. So I think it's slightly less spectacular than a dedicated group necessarily, but we're getting better at it at grassroots. And the other thing is about the I statements. I think the government has come in and set out series of I statements and we statements. We need to take note of that and ensure that that's built into our governance arrangements. But what they closely reflect are the I statements that we've already come up with through the development of our adult social care strategy, and that has been created on the back of a load of co-production and engagement with people out there. So I think what we already do have is a sense of where we want to go that has been co-produced. The challenge now is to reconcile that with what the government are telling us about how we're going to be inspected, and then evaluate progress against that. So it's the strategy is absolutely core part of inspection readiness, because that's setting out where we want to be.
Thank you. I was going to ask about the strategy and alignment, so you've answered that beautifully. And just to say that, yeah, the point about feedback that you've already got being made best use of is a really important thing. So I really welcome that sort of focus, I guess, and taking it down to that team level so that people learn how to respond is the really sort of like the nub of it, where feedback kind of actually gets fed back into the operational delivery. Is, you know, that's the only point at which it's really going to make an impact. So that's really good to hear.
Okay. Ruth.
Yeah, thank you. Oh, hang on. I'll just press something. Yeah, a bit of a follow-up from Lucy, what Lucy was just saying actually, about continuous improvement. I'm really, really interested to just drill down and see how you undertake continuous improvement and whether you're making any change to how that happens, and what kind of systems are in place, you know, or whether you're making a change to that. So do you use a more command and control style, or the more continuous involvement in continuous improvement? So that there's the Japanese model, the Toyota way is referred to, isn't it? Where there's a cultural expectation within the organisation that every member of staff is involved in continuous improvement on a day-to-day basis, not just annual review or periodic surveys, but actual day-to-day, and that there's an expectation that everyone has their say, and that's actually part of their duty as an employee. I'm not sure that's a culture we could fully adopt in the UK, but it's I'm just really interested to see what kind of structure and culture you've got going on.
So there's a council-wide project looking at continuous improvement, which we're linked into, and that is trying to establish what tools and support the council can give to each of its services to promote that culture of continuous improvement, and to sort of standardise it and share best practice. But I think what we're, and that will be a part of this, and we'll take that learning. But I think fundamentally what we're talking about here is ensuring that each team, each line manager, in team meetings, in one-to-ones, in annual reviews, but more importantly in the day-to-day life, is having that conversation about ultimately what the strategy means for us. Where are we looking to be? Do we know how we're doing? We think we know. You know, what evidence have we got that is the truth? And where do we want to be? You know, it's understanding where we are, and it's goal setting, and that wraps up at each tier into a performance management dashboard at a more senior level. But it's about individual behaviours and culture change that fundamentally we're promoting through this, and through the embedding of a performance management framework.
Thank you very much for the question, Ruth. And it's a really good question, because it's really at the core to what we discussed when we embarked on this journey last year, was about the kind of culture that we wanted to create within adult social care. Because for me, I've been around, like as many people have been around, about continuous improvement tools over the years. But for me, the crux of it is about empowerment, and about a culture of learning, and about enabling open discussions to be had. And that's the approach in which we've taken to this within adult social care. And for me, there's an approach which I really liked, which is called value management, which is about very much that that enablement of that ownership and that culture of learning right throughout. And for me, you know, what's been really important through this journey of developing the improvement frameworks to right through to taking this forward is by having open discussions with our teams and having and enabling our workforce to be involved and to have a view and have a say in how we go forward, as with the people that we support. It's that culture that ultimately for me is the backdrop and the conditions that ultimately, you know, creates a culture for continuous improvement and quality and going forward. And it's, do you know, one of the things I quite liked within this CQC assurance framework is I talked about leadership, you know, within this. And I think that for me, one of the things I really talked about is that compassionate and open leadership. And for me, that's one of the cruxes and the cores to this and how we go forward, is that we want to have a leadership that supports and enables an innovation and discussion about quality and about how we ultimately improve the lives and outcomes for the people of Sheffield, but also from our workforce, whether it be within the council or for me, as you know, as right across all the 10,000 workers of social care across the city, is that very much that positive workforce that we want to have.
That's all really, really good to hear. I'm really encouraged by that. Yeah, really good.
Right, I'm looking at whether members have got any other questions. So, Lucy Davis.
Sorry. I think I mentioned last time the sort of, I guess, the slight tension with sort of, I guess, the risk of the introduction of a framework where that becomes the driver for the work that you do, and how you kind of reconcile that with like your own strategy, what you're hearing from people locally. And I guess just to sort of drill down into that a bit further, I'm just wondering about, obviously we haven't got the details of the assessment framework, but I was wondering around about issues of sort of equality of access and whether the framework had that as a focus, because obviously I think, you know, we've talked about locally needing to have that embedded as a driver in terms of looking at people's experiences and whether that's impacted by their different ethnicity or their different, you know, sort of cultural background, many other factors. And is that likely to be in the framework? And if it's not, how will we make sure we stay focused on it?
Hi, Lucy. It is a part of the framework. I'm scrambling from the papers now, but it's one of the I think it's one of the quality statements specifically relates to equality, and if I'm able to find it for you as well, I think I can find.
So in the how local authorities can ensure safety within the system, it talks about we make sure that people are always safe and protected from bullying, harassment, avoidable harm, neglect, abuse and discrimination. So one of the, so that discrimination, I think it starts to get into the equality of access. It doesn't, I mean, obviously, there are elements of that, but it starts to get there. It also talks to people, there is another element of it somewhere.
There is. It's workforce equality, diversity and inclusion. We value diversity in our workforce. We work towards an inclusive and fair culture by improving equality and equity for people who work for us. So it's one of the high-level themes in the framework, which will be driving our agenda.
And regardless of whether it's in the framework, it's also something we care about. I think your point around whether it is solely the framework deciding it broadly, I think Alexis probably, as DAS, would agree the framework measures the right kind of things within adult social care. It shouldn't distort behaviours too widely, but it isn't the only thing driving it, and you'll see those kind of, hopefully are seeing that kind of statement and action in what we're doing on every day and our strategy and the rest of our conversations through the change programme, etc.
Well, I think your point, Lucy, is really well made, and I think it came up at the last committee, is that one of our key driving forces behind our quality improvement agenda is not to, in a sense, be ready for CQC assurance framework, is to actually improve the lives and outcomes for people at Sheffield. And that's ultimately what we're doing this all for, and to ensure that people experience high quality services no matter which part of Sheffield that you live in. And, you know, for me, it's always that balance between recognising you've got an assurance framework, but also recognising you need to also do the right thing, you know, locally, and drive the right things locally. And that's what we've tried to do by our alignment of our strategic focus through our strategy, as well as taking that forward right through to our own performance improvement framework. And one of the key things that we've also done locally is develop a set of shared health and wellbeing outcomes as part of this. And one of the key outcomes based on conversations locally was about drawing out and focus on inclusivity and diversity, and how we're actually practically doing that within Sheffield as a system. And so I think, you know, it's, for me, what's really important is that, just as colleagues have said, is that it's really important that we're getting that alignment, but our focus is doing this for the right thing, to ultimately to get the right outcomes for people. And that's our driving force for that. And it would just be really great that we also got that well read as well within the inspection framework. But, you know, I think that the key thing is about people here and what people expect of us in adult social care. And certainly for me coming into post, it's been, what's really important is about setting a standard, and that's what the role of the DAS is, to set a standard. And this is what my team has been really good at doing over the last year, is, you know, really working with colleagues to set that standard and to develop something we can tangibly measure and show that we are making a difference in people's lives. And that's really what counts.
Thank you.
Okay. I can't see anyone else indicating, so can we move to the recommendation, which are to just to sorry.
I think it's note the report and provide comments, which
We've provided comments, haven't we, which we've recorded, and so can we agree, members, to note the report for the minutes? Yeah. Okay. So thank you for that. Report 2 is the transformation programme update. Alexis, would you like to lead on that? Cheers.
So what I'll do is I'll give you a very brief introduction, and then I'm going to hand over to John to say a couple of words. So again, thank you very much for the opportunity to speak today about the Adult Social Care Change Programme. And the context is very much is that last year I came to the committee to talk about, we undertook a self-assessment and that identified some key priorities that we need to take forward within adult social care. And what that led to was the development of a change and transformation programme, and very much part of that was about the cultural change across the organisation and the service. And you know, and what we've undertaken is very much, you know, implementing that over the last year. And the report gives details of the progress made so far around some key themes. And you know, for me, what I just want to draw out is that over the last year, what we've really focused on is strengthening our governance range, which you've heard a bit around just there in terms of the programme of inspection readiness, with leadership arrangements by strengthening some of our leadership arrangements within the service, but also developing and co-designing and co-producing a strategic plan for adult social care that gives us a direction of travel towards very much early intervention and prevention, and so that people could live independent and fulfilled lives within Sheffield. But we've also taken forward some really practical activities, such as strengthening integrated working in the city with kind of colleagues in housing, with health, with the VCF, a focus on transitions for young people, because we recognised that was absolutely something that people were telling us we really need to prioritise and focus on. But equally, developing our joint commissioning arrangements further, so that we are using our joined up health and social care funding in the best possible way. And finally, very much responding as a system to the pandemic and the significant impact that that's had, you know, across the piece. And the change programme that we've undertaken has been very much incorporating all these different elements, but absolutely driving forward, you know, a significant cultural and strategic and system-wide change, you know, that ultimately the crux of it is to improve lives and outcomes for people, to improve the, you know, the opportunities for our workforce, and also create a sustainable adult social care for the future. And on that point, I'm going to hand over to John, who's been instrumental in putting it all together.
So I'll briefly, thank you, Alexis. I'll briefly talk through some headlines from the programme. We're giving you quite a high level end of a long meeting, and we're giving you quite a high level summary here, but we're very welcome to provide more details afterwards or go into detail now as you see fit. the change programme is the vehicle for delivering our strategy, basically. Our strategy, which you've seen and is being considered by the Co-op executive this very afternoon. We're quite excited about, I think, the ambition within that over a long period of time. So it's a 10-year strategy, it takes us up to 2030. The change programme is the vehicle to deliver it. The main benefits that we are reaching for are firstly around the quality of experience, the personal outcomes, the quality of life for the people that we are serving and supporting in Sheffield. Secondly, around our compliance, our safety of our systems, etc., which are driven a lot around the care governance stuff, which Liam has spoken so eloquently about already. And thirdly, around the financial sustainability of the adult social care system in Sheffield, which is a challenge for every local authority everywhere, and you will have noted through your scrutiny of the budget and involvement in improving the budget various elements of that. So effectively, three main benefit areas. There are four chunks we have split this into work streams. One around our models of care, so one around how the care delivery is set up, how the overall experience of care is set up, not in a way of just thinking about bits of procurement, although that is part of it, but actually how that fits into together to support someone's whole life in a variety of situations. So that leading strategy through to care delivery. A second one around our operating model internally, where I think it is fair to say that there is always room for improvement, and that is driven by how our processes work, how the people across the adult social care system, of course, not all of those being our staff, in fact, a minority of those being our staff, between providers, between voluntary sector, between unpaid carers, etc., how that works together, and of course with health partners, and GPs are a crucial part of that, as are district nurses, as our hospital colleagues, and many I haven't mentioned. So how that fits together for a coherent experience in terms of how that works behind the scenes to make sure it is a coherent experience. Thirdly, our care governance, which again I've just alluded to, and Liam spoke already about that. And fourthly, around our workforce, our communications, our culture, which again we have touched on in the discussion before, and I think is relatively self-explanatory from our name. Across that programme, we are looking very closely at our co-production approach, and that's something that's not just in one work stream, but we're looking at across, and I wanted to just pick out as the one thing I picked out from the read across, acknowledging that I think we have some really strong areas of individual co-production, the strategy being one of the most recent, but some excellent work around our direct payments development, for instance, and several others I could list off, but trying to make sure that we are more systematically building the voice of the people we serve, the voice of the people who work in our system, across the system, in our improvement, and we have touched on this already. I don't propose talking a lot further about this on spec, but I'm very happy, we're all very happy to take questions or and come back. Obviously, it won't be to this committee, but to the new Health and Adult Social Care Committee with more information as steered and as we can support that new remit.
Thank you. So over to members, questions, comments. Stunned silence. Can I take that as a sort of an affirmation that we generally, sort of agree with the approach and the recommendation? Well, it's not a recommendation, but that it will come back to a successor, whatever the successor body is, the subcommittee, when it goes through the whole process goes through the council next week.
Chair, it won't be the subcommittee, it'll be the policy committee.
The policy committee. Yeah, sorry. I'm still a bit confused as to where it goes, actually, but yeah, okay. So, are we happy to agree that? Yeah. Can I thank Alexis, Duggan, and Liam, beg your pardon, and John for your attendance today, and thank members. And as it's our very last meeting in our current form, a historic one, I think. So can I thank you, members, for your participation throughout the year, and see you in another life, I guess. Thank you.
And we're finished on time.